We begin with our talk early abdominal ectopic pregnancy challenges, update, and review of current management. This is a TOG article. Okay, less frequently asked, but sometimes abdominal pregnancy has also been asked. Ectopic is going to be very, very important from the examination point of view. So, abdominal ectopic occurs in the abdominal cavity, excluding the tubal and ovarian pregnancies. Early abdominal pregnancy is rare but associated with high mortality. Symptoms are similar to other ectopic pregnancy. A high index of suspicion is crucial for diagnosis. Ultrasound is the preferred diagnostic tool, and when combined with clinical evaluation, ultrasound has got only 50% accuracy. So this is the one thing where ultrasound accuracy is less. It is only 50% in abdominal pregnancy. Okay. Now, what are the different implantation sites? It is uterine serosa, pouch of Douglas, omentum, bowel, mesentery, mesosalpinx, pelvic and abdominal wall, peritoneum, liver, spleen, diaphragm, fascia of Girota. Okay, these are the different sites. But out of these, common is the pouches surrounding the uterus in a 55 cases. So there is a one study which a series of 225 cases. So maximum were in a pouch of Douglas, primarily posterior in the pouch of Douglas, and another next site was a cirrhosis of the uterus and adnexa. Okay. So incidence is around 1% of all ectopic pregnancies. It occurs in around 1 in 2200 to 1 in 10,200 pregnancies. Mortality is 7.7 times higher than the tubal pregnancy and 90 times higher than the intrauterine pregnancy. These figures are not going to be important, but just from the gravity point of view, we should know. Okay, it is often missed preoperatively. Only 1 in 9 cases correctly diagnosed before surgery. Okay, so early, abdominal pregnancies are missed most of the times. Only 1 in 9 cases are correctly diagnosed before surgery. Early diagnosis and intervention are crucial to reduce the mortality. ART use is increasing, but ectopic pregnancies, especially the abdomen, has got no relation with ART. Okay, means ectopics are increasing because of the ART use. However, the prevalence of the abdominal pregnancy is not increasing with the ART. Okay, that is what they want to say. Okay, mortality trend has improved over a period of 20 years, and the mortality has come down from 20% to 5% with early intervention. Then classification of abdominal pregnancy, there are two types. One is early abdominal pregnancy, which is less than 20 weeks or equal to 20 weeks. And second is a late abdominal pregnancy, that is exactly more than 20 weeks. Okay. So by implantation site, you can divide it into primary or secondary. Primary means implantation itself is in the abdominal cavity on some organs. Okay. It's not on the tube and ovaries. And secondary, that means initial implantation is in the reproductive tract, and later on it gets implanted into the abdomen. Secondary abdominal pregnancy occur in 1 in 10,000 live births. This classification, primary and secondary, is not clinically relevant. Okay, so it is more of the academic classification that will not affect the management as such. Okay, but management, this gestational age classification, that early or late, that is important from management point of view. Now, what are the diagnostic criteria for a primary abdominal pregnancy? There are study Ford's criteria. Tubes and ovaries should be normal. There should not be injury. There should not be uteroperitoneal fistula. Pregnancy should be confined to the peritoneal surface, and diagnosis is made early, rules out secondary implantation. Then, as per the Friedrich and Rankin's revision, gestational age they have added, it should be less than 12 weeks, and trophoblast should be attached to the only to the peritoneum. Okay, so these are the diagnostic criteria for primary abdominal pregnancy. Now, what are the risk factors for early abdominal pregnancy? One thing we are going to remember here, that which does not have ART, does not have association with the early abdominal pregnancy. Okay, it is rare. Okay, so same as other ectopic pregnancy, the risk factors like prior ectopic pregnancy or tubal surgery, endometriosis, PID, current intrauterine device use. IVF related risk is rare. It may be because of the uterine perforation during embryo transfer, or there can be oocyte migration with abdominal fertilization, or microfistulous tract in the uterine isthmus. Okay. Despite increased ART use, there is no rise in the early abdominal pregnancy incidence. Okay. Now coming to the diagnosis of early abdominal pregnancy. Signs and symptoms, they are highly variable, no specific symptoms to distinguish from other tubal ectopic. It requires high index of suspicion, often diagnosed intraoperatively either by laparoscopy or laparotomy procedure, may require multiple surgeries before correct diagnosis is made. Investigations, serum beta ICG, again here beta ICG is not helpful. It is non-specific and not diagnostic for early abdominal pregnancy. Second, investigation is ultrasound. It's first line diagnostic tool, but limited accuracy. We have already seen hardly 50% accuracy they have mentioned when used with the clinical assessment. Critical for identifying location and organ attachment, which guides the management. So here will be the role of MRI. Okay, when we want to know the attachments and all the details. Okay, but MRI during pregnancy is contraindicated, but still here we can, because maternal life is going to be important, so we can carry out the MRI here. Okay, so key ultrasound findings suggestive of early abdominal pregnancy, uterus will be empty, gestational sac or fetal parts separate from the uterus, adnexa and ovaries. Mass will be seen in the abdomen away from the pelvis, showing pregnancy features like fetal heartbeat, etc. There will be no uterine wall between the bladder and the fetus. Okay, normally you see that anteriorly there is a uterine wall between the fetus and the bladder. That will not be there. Uterus will be visible as a separate structure from the gestation, and fetus will be close to the abdominal wall. Placenta will be located outside the uterine cavity. Okay, but there are certain diagnostic pitfalls, may mimic or confuse diagnosis, which may be because of uterine fibroids, retroflect uterus, or intrauterine pregnancy. Cervical, intramural, cornual, or bicornuate pregnancies can give false positive. Okay. Then what is the role of MRI? It is useful when the ultrasound is inconclusive, better for mapping organ involvement than initial diagnosis. Gadolinium contrast crosses the placenta, generally contraindicated in pregnancy, but can be used with the consent if the maternal life is at risk, including possible consent for termination, preferably done before surgery to aid the planning. Okay, so when ultrasound is inconclusive, we'll go ahead with the MRI. Now, intraoperative imaging, they have mentioned here intraoperative imaging with a laparoscopic ultrasound or the transvaginal ultrasound. Okay, it may assist diagnosis, and the postoperative diagnosis will be on histopathology, which will confirm early pregnancy, early abdominal pregnancy by showing tropoblastic proliferation and neovascularization involving the attached organ. Okay, that is the post-operative diagnosis. Pathophysiology, we will not go into the detail because how exactly the abdominal pregnancy develops. But there are many theories they have mentioned, not required from the examination point of view. That is why I'm keeping the slide. Then treatment for early abdominal pregnancy. So high maternal mortality due to implantation, highly vascular surfaces, risk of sudden massive bleeding anytime during the pregnancy. Key factors affecting the management are maternal hemodynamic status and gestational age at presentation. Medical management is used when life-threatening bleeding is anticipated. When you have a splenic or hepatic early abdominal pregnancy, medical management, because operating at those places is very dangerous. So medical management will be preferred. Then agents which are used are methotrexate, potassium chloride, hyperosmolar glucose, prostaglandins, danazole, etoposide, mifepristone. These are the mentioned in the book. Then limitation, no standard guidelines or reliable predictors of success, often require subsequent surgery due to hemorrhage. So arterial embolization may be used preoperatively to reduce the vascularity and the bleeding risk. Also used postoperatively to control the bleeding from retained placenta. Surgical management requires experienced surgeon and often in a multidisciplinary team. Expectant management is unsafe in second trimester due to risk of sudden hemorrhage and poor fetal outcome. Immediate surgery is recommended once diagnosed, especially if the fetus is dead, to prevent the infection and DIC. Okay. Now surgical technique, either laparotomy or laparoscopy. Previously, traditionally it was a laparotomy. Now increasingly managed by laparoscopy in early cases. Hemorrhage control methods during laparoscopy, like you can use bipolar electrocautery, harmonic scalpel, hemostatic agents can be used, vasopressin, fibrin sealants are available. Okay, so these are the methods of termination. Okay. Outcome, laparoscopic surgery is associated with reduced blood loss, shorter hospital stay, high success in early abdominal pregnancy, post 2000, year 2000 onwards, 100% laparoscopic rate in early abdominal pregnancy have been mentioned. So laparoscopy has been used in hemoperitoneum cases successfully. This is what the TOG article mentions. Okay, so that finishes the topic of early abdominal pregnancy.